I moved to Dubai 31 years ago, United Arab Emirates, and the first American-trained pediatric dentist, where I became the first diplomat of the American Board of Pediatric Dentistry in the old format. So I have a grandma status now. Dubai has just hosted World Expo 2020, and I'm delighted to share with you the video of the expo that gives you a glimpse of my city.
We promised you we'd be ready. So while you were away, we have worked on so many new reasons for you to visit Dubai. We reached for the sky and discovered new depths. We have welcomed new friends from all walks of life. We found you more places to stay and spaces to take a pause. On top of all your favorites, all safer than ever before. Oh, and one more thing, Expo 2020, the world's greatest show.
I see some familiar faces who've come along from Dubai, and they're part of our Emirates Pediatric Dentistry Club. So the Emirates Pediatric Dentistry Club started in 1991 with one person, and today we pride ourselves in 250 colleagues. On the right side of the slide, that's me anchoring the opening ceremony of the first event in 1991. And on the left side, this group of gentlemen built a company called Index that currently organizes the largest dental conference and exhibit in the world, ADEC. So this is my late father, he was a prosthodontist, my mom, she's an orthodontist, and myself in one of our events. This is me in 1965 on my mom's lap on this Shirana dental unit, and this is 57 years later, and you can see this dental unit has turned to be a memorabilia, and we have a pulley. This is how they used to use their slow-speed handpiece. To move to the core of the matter, we know that mindfulness and coaching mentor us to build on failures. However, in pediatric dentistry, it's a bit more challenging to have a failure. Because whenever we have a failure, it means this little child who has to come back for another difficult visit, parents who are going to take off their schedule, take time off their schedule, and us as pediatric dentists defending why it failed. So this made me go back to review and check. Am I hurt in the back? Is this better? Yeah. Thank you, thank you, thank you. So going through the guidelines, they all literally build the treatment planning of the diagnosis. So it's always the diagnosis alone that dictates the treatment plan. And this basically applies to all different guidelines. So the conventional approach is we care for the patient, we assess the chief complaint, we offer a comprehensive assessment based on clinical and radiological evidence. So basically radiological and the clinical examination, come up with a diagnosis, come up with a treatment plan, and perform the treatment plan. This works in many cases and doesn't work sometimes. So we're going to look at the cases where it worked. And this set of bite wing, right side, left side, the blue circle shows the interproximal lesion, limited to the enamel, going by the guideline. We just ask the patient to work on a preventative fluoridated regimen, come back to see us frequently to have fluoride application, brush 3 times a day with fluoridated toothpaste, floss, and use one of these mineralizing agent like MI-Paste, Tooth Smooth that we find on the market on a daily basis. And yes, it did work. However, in this case, this is a deeper lesion that extends to dentin. And going by the book, the patient should have come back for treatment. Patient didn't come back. 6 months later, we have a lesion that's in proximity to the nerve. Now, this blue little box will pop up every time things don't work well. This brings us to a topic and to a science that we're literally, one more time, paralleling from the medical world, and it's epigenetics. So what does epigenetic mean? Epigenetic is the study of how our behaviors affect the environment and dictate how our inherited genes are going to express themselves. Example, I carry predisposing factor for periodontitis by having extremely healthy lifestyle. I brush well, eat healthy, I'm not going to develop periodontitis. However, if I carry predisposing gene for periodontitis and I don't eat well and don't brush well, I'm going to develop periodontitis. Basically, it's how I behave that will dictate the environment and that will dictate automatically how my genes are going to express themselves. This, for us, is another breakthrough because it means within the framework of the guidelines, we have to look for personalized treatment plan. We have to tailor our treatment plan depending on the patient. Another case, this is a deep cavitation, but upon probing, it's very hard. Place the patient on a heavy preventative fluoridated regimen. 2 years later, and an additional 2 years, and we can see that the lesion is totally remineralized. Well, this is a case of deciduous molar hypomineralization. It's basically the primary teeth version of MIH, molar incisor hypomineralization. And this literally was not a cavity. So one more time, we have to tailor what we do on one-on-one basis. Now I'm going to move down to failures in comprehensive work. And I work in an area where we have very high caries risk. So our TMFT in small letters for 6 years old is 6 to 8, which means in a 6-year-old child, out of 20 teeth present in the oral cavity, you're going to have 6 to 8 teeth that are caries. Of course, severe cases of early childhood caries, a lot of emergencies, and patients who need to have anterior teeth restored. And I come from the time where we used to use acrylic white facing bonded to stainless steel crown, what we call preveneered crown. And we used to perform this beautiful work under general anesthesia. However, the bonded white facing used to fail us. And the patient used to come back to us walking around with metal teeth. Now what do? We can't tell the patient we're bringing this child back to OR, we're going to take him back to OR, we can't do that. And sometimes these episodes would happen very soon, because we have to think that though we work hardly on oral hygiene and diet practices, can eat all kind of gluey, bonded stuff, gluey stuff that literally are stronger than our adhesive bond. So we used to have to do it on the dental chair. And this used to be a very big challenge. It means I have to cut these crowns on the dental chair and replace them. Well, this was sorted out because nowadays we have zirconia, and it is a breakthrough. I've been using U-Smile since I started, and yes, we've achieved amazing results with zirconia. So, extensive anterior lesion, restored by pulp therapy and crown, did extremely well. You see how young this child is, 18 months, 2 years old, very young toddlers. Primary incisors haven't erupted yet. 5 years later, he shed his baby incisors, his permanent incisors erupted, the teeth are doing extremely well. Amazing result. Irrelevant to what I'm talking about, he developed crossbite because he has a habit. He has a passing. Another successful case, interproximal lesions. We know that composite filling would have failed, strip crowns would have failed, zirconia, amazing result. 2 years later, and I'm always amazed at the aspect of the gingiva, the healing around zirconia. Literature review, we just published this article. In fact, it's published in the European Journal of Dentistry. And it's an evaluation of the clinical performance of U-Smile periodontic zirconia crown in pulp-treated primary teeth, 2-year follow-up study. And the conclusion was zirconia pediatric crowns are well-suited restoration of choice for primary teeth rehabilitation. Always amazing, lasting results. However, one more time, it's not always the case. So we've seen some failures. Why? This is a complex trauma case involving enamel, dental, and pulp. Teeth were restored with pulp therapy and zirconia crown, and surprise, the tooth stopped erupting. Why did it happen? One, it can be due to the initial trauma when the patient came to see us. So basically there was an injury to the periodontal ligament, maybe a minimal intrusion. We can't really tell whether there was an intrusion because often these teeth aren't fully erupted. So teeth, you see that the back teeth haven't yet erupted. These are very young kids because we know that the majority of this trauma happened for toddlers between 1 and 3, 72% of the trauma. So we're not sure whether this tooth was a bit intruded and as a result stopped erupting, or whether, because I performed a complete pulp therapy, pulpectomy, I basically impaired the normal eruption path of the tooth. Or, because these teeth were not fully erupted, and whenever we have to prep the zirconia crown, we have to do aggressive preparation, subgingivally, where I literally inflicted an injury to the periodontal width. So I harmed the tooth, and the tooth stopped erupting. So yes, zirconia is really nice, but one more time, we have to weigh. Are we supposed to extract, or shall we keep the tooth? Shall we inform the parents that there is very high risk of these teeth being retained or ankylosed? I'm not sure what we can call it. Because in another case, surprisingly, the child came to see us 1 week after the trauma. He had developed an evident pulpal polyp, and we needed to do a complete pulp therapy for this teeth. And one more time, the tooth stopped erupting. But surprise, it re-erupted again, just on its own. We have to keep in mind that are all very, very young children. So going back to the literature, 80% of the intruded primary teeth re-erupted spontaneously. However, nearly 1/3 of the teeth showed complications, such as pulp infection, periapical inflammation, or ankylosis. But this is only in cases where teeth were intruded. Another steep learning curve of zirconia, V-shaped palate, child is a success sum, restored it, patient came back, the teeth discolored. So what happened? Now we know that whenever we have to cement these teeth, we have to really control the profuse bleeding, because we often go subgingivally in the preps, because this profuse bleeding is going to taint my luting cement, so the teeth turn gray. Again, the blue box, so we have to employ an hemostatic agent to control the bleeding prior to cementing the zirconia crown. So new technologies, they have steep learning curve. I call it the endless learning curve. Now, literature review again recommends the usage of peckable glass ionomer is more retentive than bioactive cement when used for cementing zirconia crown. Posterior zirconia pediatric crown have high fracture resistance after 36 months of clinical performance, irrespective of luting cement. Right, but we have to know our homework. And in this case, kindly have a look at this X-ray. It shows interproximal lesion, loss of mesiodistal width. Of course, the occlusal plane on the second primary molar shows a bit lower than the first primary molar, probably due to loss of structure on the opposing tooth. The tooth at rest, so over-erupted. Place 2 crowns. 1 year later, boom. Child comes with a fracture of the buccal wall. All right. Why is it? Because as pediatric dentists, we're used to placing stainless steel crown. Stainless steel crown are snap-on. Look, you hear it. Zirconia crown have a passive fit. You literally have to hold it in place till the cement turns hard. So now we know that the zirconia crown cannot sustain premature contact, and we really have to prep very, very small preparation so we can easily insert this crown and just hold it in there. So it's a passive fit. There's no snap on. I'll stop for a minute and I'll move another category of failure. This is little Olivia, and she's a star because she discontinued her passy habit, her dummy, on her own. So let's listen to what she has to say.
She's our star. Yeah.
Do you want to tell her what you did to the dummy?
What happened to the dummy? Oh.
And now you are?
Good job. You are.
She's adorable.
So Olivia is our star patient. However, very few children can discontinue their habit on their own. And I'm going to meet what Dr. Akaria was talking about. And we know that all cases of malocclusion are a result of mouth breathing. And habits develop mouth breathing. So whenever we have a child who breathes through the mouth, automatically the tongue sits on the floor of the mouth. The tongue is meant to sit on the roof of the mouth because that's how we can breathe through our nose. Would you please try it? Just, would you please close your lips, seal your lips, and take a deep breath from your nose. And you can see that your tongue sits on the floor on the roof of your mouth, I'm sorry. Now would you please open your mouth and try to breathe? Where does the tongue sit? On the floor of the mouth. The tongue is the leader. Whenever my tongue sits on the roof of the mouth, the rest of the muscle of the orofacial structure are going to fall into place, resulting in nasal breathing, correct swallowing, and perfect occlusion. Whenever the tongue sits on the floor of the mouth, the rest of the muscle of the face have to adjust to breathe, swallow, and the tongue is down. And this is going to cause these muscles to just take all different dimensions in order to allow our basic function of breathing and swallowing. Going back to the etiology, Doc, and I fully agree, there's one more etiology, and that's cow milk. And we know, as an old pediatric dentist, we didn't used to see the prevalence of mouth breather that we see nowadays. Nowadays, 9 kids out of 10 are mouth breathers. So cow milk, even if the child is not intolerant or has clear allergy to milk, he will develop sometimes certain sensitivity to milk. And cow milk causes inflammation of the airway, meaning these little children, we feed them on cow milk and they open the mouth because they can't breathe because the milk has caused them minimal inflammation of the airway. Now, one of the techniques we use is myobrace. Myobrace is a technique that trains the children to, it's basically a rehabilitation to train the children so the tongue goes back on the roof of the mouth. And in order to do that, because the tongue is a very powerful muscle, it takes 6 months to correct the bite automatically, without braces, without aligners, without fixed mechanics, but it takes 1 year for the tongue to train to sit on the roof of the mouth. So this is a very short video that explains how the myobrace works.
The myobrace appliances work by teaching your tongue to rest in the correct tongue resting position.
So the myobrace in the mouth, the tongue is forced to go on the roof of the mouth, and the nose is never 100% blocked. There's always patency. And the child starts breathing from the nose. The minute we train the tongue to go on the roof of the mouth, what follows is a correct swallowing. Because it starts with breathing and ends up with swallowing. Whenever we want to swallow, if our tongue is in the middle of the mouth, the tongue is going to sit in the middle, between the arches, or on the floor of the mouth, ending with open bites. Okay? That's why orthodontists don't like cases of open bite, because they're going to close the space, the open bite, and very quickly the tongue that's used to being in the middle, we swallow 2,000 times a day, is going to go back in the middle and causes a relapse of the case. When we restore correct breathing, you never need any appliance, any retainer, because every time the child breathes correctly through the nose, the tongue is positioned on the roof of the mouth, it's going to be retained just by normal daily functions. So I'm going to show you successes and unfortunately failures too. So this is a case of severe bite, of severe deep bite. We literally don't see the bottom teeth. And we can have a look at the arch, and just like doctor was saying, we have a V-shaped, steep vault of the arch. Just by restoring nasal breathing, training the tongue to go on the roof of the mouth, and giving the tongue activities, because the tongue is a muscle. So you need to train. This V-shaped palate turned into a broad U. This is without an expander. And at the same time, the minute you grow the top arch, your bottom arch follows. A severe case of overjet, restored in 1 year. Now, the next case is very interesting. That's my failure. This is a child who came in, and the chief complaint was the anterior diastema. However, I'm the smart one, I'm the pediatric dentist. So I thought, well, the diastema is a problem. It's not a big problem. The problem is the direction of growth. This child has a retrusive chin, a very short lower third, and a deep genial pit. So, and this child is, of course, a severe mouth breather, and she has reverse swallowing, so all the features. Retrusive chin. So what does the myobrace do? The myobrace brings this bottom jaw forward. It literally moves the bottom jaw forward. And we corrected this 14 millimeter overjet to 5 millimeter. And of course, whenever the top arch turns into a broad U, the bottom arch can fit better. And of course, the tongue has more room to go up on the roof of the mouth. So we corrected this overjet. However, and you can have a look at the face, how it becomes more relaxed, and we lost that deep genial pit, and the lower third increased in height. It's amazing, really. Nothing can do that but biofunctional appliances without braces. But the child wore, we need compliance. So the child wore his appliance and he did his exercises. We have activities. I call it the gym for the tongue. And very similar to the speech therapist activities and exercises. Well, the mom was extremely happy. And I lost the patient and his family and all the friends, because the mom came with a chief complaint. She wanted to have the diastema closed. And I told the mom once she came back that we're going to put braces just for 6 months to close the spaces, because everything else was corrected. And she was extremely upset, because I wasn't clear enough. I didn't communicate well enough to explain, but at the end, we might need a few brackets just to level a line and close the diastema. Okay. So, the take-home message, within the conventional guidelines framework, tailored treatment plan. We love guidelines, but sometimes we have to put our personal input. There's no one size fits all. We have to anticipate the challenges posed by zirconia's steep learning curve. We have to keep learning. In trauma cases that require zirconia crown, opt for partial instead of complete polytherapy to reduce the risk of ankylosis. And finally, be attentive to the patient need and focus on interactive communication. Ladies and gentlemen, thank you for your attention.
Speaking of problems, anticipating problems, what problems have you encountered with zirconium crowns causing problems with the natural enamel, natural wear or damage from the crown itself? Particularly like with the interior crowns not having enough overgel, and what damage it might cause some farther zirconium crowns on posterior teeth, causing premature wear on the
Opposing teeth.
Yes.
Right. It's a very good question, doctor, because basically as a pediatric dentist, our population is the very young ones. So yes, we do see them. But I haven't had really, one of the things that we see, and this brings back the topic of myofunctional appliances, we know that children that grind they're all mouth breather. So in general, if you have a severe grinder who really cries, have a look at the occlusion. You're going to see some problems with occlusion that are all signs of mouth breathing. So yes, I fully agree that we do see wear on the opposing teeth, but in general, if the wear is severe, then I would be investigating a bit more his mouth breathing, and just like Doc said it, I would just ask the parent, if you ask the parent, does the child breathe through his mouth? They would say no.
They say no.
But then for me, now, you know, as an old person, the minute I see a child walking to the office, I just see, is he walking with his mouth open or not? And then the next thing I threaten, and now I phrase it differently because I don't want to offend parents. I just say, would you please check at night if his mouth is open? And that, as doctor said, you don't have someone who's 100% mouth breather. It depends on the severity. So patients who are mild mouth breather, they will have +1 occlusion plus misalignment, so shortage of space. Patients who are a bit more of